Hi, I'm Jerry Hesch, physical therapist at Hesch Institute in Aurora, Colorado, and we teach body of work for treating the whole body and treating the sacroiliac joint. And we teach that to healthcare professionals, and we also treat clients with chronic pain when they can't find good or reasonable or lasting help elsewhere. We perform very thorough evaluation, very thorough treatment. This is a presentation on the type of sacroiliac and coccygeal dysfunction, which I discovered it's not in the body of literature on sacroiliac joint dysfunction. And I have named it lower wind-swept pelvis. And it seems to involve the entire pelvis as it moves on the trunk, involves the hip joints, also involves the lower pubic joint, and if you have a movement dysfunction in the pubic joint, there's only one hemipelvis that connects to the sacroiliac joint. So it's fair to say that it also involves the sacroiliac joints. And with this pattern, there are 6 components. And the very first component is that in palpating the lower pubic joint, there is a lower pubic posterior rotation, and this happens on the left side. I've never seen it on the right side of the body. And so there's symmetry at the upper third, symmetry at the crest, symmetry at the middle third, but when you get to the lower third, there's a distinct posterior rotation on the left. This correlates with the back of the pelvis, the ischium, the lower part, being posterior due to that rotation, and it will lack spring mobility, spring recoil mobility when you try and induce passive movement with about 10 to 15 pounds of force taking up the slack and then another 10 to 15 to perform the spring test. With that pattern, I've also found that finding the midline crease, we find that the right sit bone, the ischium, is closer to that midline, palpating medial part of the ischial tuberosity to the midline crease, and we find that on the left, the medial aspect of the ischial tuberosity is lateral. The coccyx is stuck in left side bending, and when you palpate up on both sides of the coccyx, because of the side bending, the transverse process of the upper coccygeal bone is superior, and therefore there is a deeper sacrococcygeal sulcus on the left side of the body. So the treatment is pretty straightforward. And what I do is I place a piece of 2 by 4 by 8 inch foam underneath the left ischium, and I have them lay supine with legs out straight for 5 minutes. This corrects the lower pubic rotation. This corrects mobility of the ischium. However, the ischium still appears to be positionally posterior. And the only way that could happen is if there's an external rotation of that ischium. And so there is not only a lateral positioning of the left ischium and a medial one on the right, but there's also an external rotation, that would be internal rotation of left hemipelvis and external rotation of right hemipelvis. And again, involves the hips, involves the pelvis as a unit as well. So I'm not saying this is only in the SI joint. And I'm not saying that I'm able to isolate that movement inside the SI joint either. I'm very aware of the literature. So the treatment is pretty straightforward. And what I do is I stretch the left hip into adduction so that I bring that ischium medially, and I stretch the right hip into abduction to bring right hemipelvis, especially the lower part of it, into abduction away from midline. So once we establish near symmetry in relationship to the midline, we will then have restored normal spring recoil mobility going medially, lateral to medial on each side, and we will have restored medial to lateral spring mobility on both sides, and both sides would have been stuck because apparently this pattern takes it to an end range. Then we palpate and find that the ischial tuberosity on the left is still prominent and a little bit lateral on the left and a little bit medial on the right, although much improved. And so what we then do is we have the client prone, we bend the knee 90 degrees and internally rotate the right hip for 2 minutes. And that's the same duration for the previous stretches, except on the pube that was 5 minutes. We then take the left hip and flex it to 90 degrees at the knee, and we externally rotate the left hip for 2 minutes. And after that, we have established symmetry of position and mobility of the ischia, anterior, posterior, and medial lateral. And then we come and retest the coccyx. Once in a while, correcting those forces and balancing forces in sacrotuberous and sacrospinous ligament is sufficient that the coccyx is no longer side bent. So we always retest it. If the coccyx is still side bent to the left, that means the lower tip is facing to the left. Then what I do is I take the heel of my hand and I capture the sacrospinous ligament and part of the sacrotuberous ligament and soft tissue as well on the right side of the coccyx. So we're pulling that coccyx to the right, and I maintain that force for 5 minutes. After that, I come and I capture the actual coccyx and those ligaments and soft tissues on the left side of the coccyx, and I literally push the coccyx to the right. And I do that for 5 minutes on each side. And I want that treatment to be a one-time correction. And I have found that this is very, very successful in correcting it long-term with a single intervention. So this is the pattern of treatment for a left lower windswept pelvis, which also involves the pubic joint and also involves a left side bent coccyx. And I hope that this is helpful, and I hope that it's especially helpful to clinicians who can then utilize this in helping the clients. And one of the reasons it gets missed is because we're not taught to palpate the middle and lower part of the pubic bone. Another reason is that for reasons I don't understand, a side bent coccyx is not on a lot of people's radar. A lot of people think in terms of a flexed or extended coccyx, but you don't see a lot of writing. You don't see a lot of YouTube videos on a side bent coccyx, and you don't see, and the traditional approach to the Sacroiliac does not teach palpation of the flat part of the ischium, and it doesn't teach palpation of the medial aspect of the ischial tuberosity, and it doesn't teach these various passive spring tests, which we certainly utilize in the Hesch method. Thank you very much.